So, in light of the crisis that Canada is facing in healthcare at the moment, particularly with respect to accessing care on the front lines, the Department of Family Medicine and the School of Population Global Health have come together to really foster a greater understanding of the current crisis and to invite experts from across the country and also from around the world to provide their insights on the nature of the problem in Canada and also its global dimensions. Solving the crisis here in Canada is not without some understanding of what the ramifications of some of our strategies, like the importation of health workers from other countries, have for not only our system, but for the systems in which they're being recruited from. So, over the course of the next 6 months, we'll be having a really exciting series of seminars, which we hope to bring together in a set of papers that we can get out to policy and decision makers with a view that we may be able to manage this crisis a little bit more effectively. So to kick this series off, Dr. Ian Scott from the University of British Columbia, who runs the Center for Health Education Studies and is also a family doctor there, is going to be reporting on the results of a study which have looked at how family practitioners use their time and have looked at that over time.
So in the research that I've been a part of, we've learned a number of things about primary care, health human resources. And it particularly relates to both the physicians that are entering family medicine, the physicians that are in family medicine, and the patients that they're caring for. So let's talk about patients first. The population of Canada is aging, it's growing, and measured by levels of complexity, it's increasing, particularly amongst the older age groups. So that complexity is increasing the burden on practicing family physicians, such that they are seeing fewer patients than they did 10 and 20 years ago. Presently, family physicians are doing about 1,000 fewer visits than they did per year than they did 10 years ago, and about 2,000 fewer visits than they did 20 years ago. So there's been this decreasing ability of family physicians to see as many patients as they did 20 years ago. What that means is that likely the number of patients that are being cared for is fewer by a family physician because the complexity of patient care is increased. That complexity is manifested by laboratory investigations, consultations, and diagnostic tests that have been ordered that have increased up to 135% over that 20-year period. This means that having the same number of family physicians per patient population isn't going to be able to serve the needs of the patient population now. One of the things we looked in our research was this trope that millennials, new physicians entering the profession, are responsible for practicing differently than experienced physicians. What we learned was that early career physicians see fewer patients than mid-career physicians, and then again that frequency of patient contacts drops in later career. So in fact, new physicians do see fewer patients than mid-career physicians, but what we learned was that has dropped over the last 20 years, not just for early career physicians, but proportionally for mid and late career physicians. So are new career physicians seeing fewer patients? Yes, they are, but they're seeing the same proportional number of patients as they did 10 and 20 years ago compared to mid and late career physicians. So this is not a problem caused by new career physicians entering family medicine. There's lots of concern about focused family practice and family physicians who are entering the profession choosing not to do comprehensive care. We have about the same number of family physicians practicing comprehensively per patient population as we did 20 years ago. So where are all the new physicians going that we're training? Well, in fact, when we look at those entering focused practice, there are physicians entering emergency medicine and hospitalist care. The feeling was that these physicians entering focused practice were new grads, but when we look at the data, there are just as many physicians entering focused practice from the starting the family physicians as there are from mid-career and late career physicians. So this relates to the practice environment where physicians are leaving comprehensive care or not entering comprehensive care across the spectrum of family practice ages or cohorts. Therefore, it's a system problem and not a new family physician problem. Given increasing complexity and the large number of patients in Canada that don't have a family physician, I think it is unlikely that we'll be able to train ourselves out of this problem. What I mean by that is I don't think we'll be able to train enough family physicians through medical school and residency to address the large number of patients that currently don't have a family physician. Therefore, if we want to solve the problem of not enough family physicians for the patients that need a family physician, we're going to need to do more than train more family physicians. Of course, we need to do that, but we're also going to need to think about restructuring the way we provide primary care in this country, likely expanding primary care to include other providers and creating more teams nationally across the country that are able to care for patients in a more effective and take advantage of the skills that family physicians and other healthcare providers can provide within a team-based setting.
So this is really very revealing with respect to the challenges that are being faced by practitioners on the front line, and I think has invaluable insights for us in terms of how we think about managing the opportunities and for family doctors in the current context. So, following Ian's remarks, we're really delighted to have moderated comments from one, the Department of Family Medicine Chair, Dr. Marion Dove, and the leader of the MUHC Primary Care Division, Dr. Mark Roper. Both of these individuals have a combination of experience and expertise with respect to family medicine and providing services on the front lines. And so we're looking forward to their comments.
I think that Dr. Scott in his presentation really addressed a lot of the significant issues. So the care of patients in primary care is becoming much more complex. And I think we have a tendency to assume that it's only older patients with multiple comorbidities who are becoming more complex. But in fact, younger patients are also much more complex. People are aware of healthcare issues. They do their research on the internet. They come in with lots of questions. We have a large percentage of the population. It's approximately 12% across the country, but in certain pockets, it's much more than that, of people who have limited language proficiency in either English or French. And I think the other thing to take into account is the feminization of medicine, where we have a lot of female family physicians who, in my understanding, tend to see fewer patients. They provide as good or better quality of care, but they tend to see fewer patients. They have maternity leaves, and they may work fewer hours. So I think there are multiple reasons why we have been unable to train enough family physicians to meet the needs of the Canadian population. That being said, there was also a decision in the 1990s by the Quebec government to cut the number of medical students who were trained, and that was based upon analysis of data that suggested that there were too many physicians in Quebec, and that I think their models were using a physician who was working 80 hours a week and seeing thousands of patients, which is just not the case nowadays, whether it be for young physicians or older physicians. People are not working those same kind of crazy hours. So there are a number of reasons why we haven't been able to train enough family physicians for the Quebec population, but those physicians that we are training are providing excellent care.
Well, what I've come to realize is that there's so much good data that we have, Barbara Starfield's research, and the fact that for every 100,000 people without a family doctor or a good family doctor team, 60 people die for every 100,000. So that held weight in politics, holds weight in court. In Quebec, we actually have consumption data for a given population and how many family doctor services they use. whether it be in a private office, in a community clinic, a hospital, or an emergency. So really interesting data. Kai-Hi it uses the Scott's medical database, which is basically the Salvin medical database, which is basically a letter that goes to your home and it's not returned, they will count you as a doctor if you have a doctor in front of your name. So very inaccurate data. It's very sad for me to see this sometimes. Medical manpower data is an undeveloped research field. Just measuring and knowing what a true indicator of access is something that needs to be done. And for example, what is a surrogate indicator of access to a family doctor? Is it having a doctor living in your community? Well, it isn't if he's working 50 miles away. Is it someone who is just a doctor in front of his name and works for Médecins de Frontières? Well, he's not servicing the community. We have some excellent data provincially in Quebec that is, I think, fertile for excellent research and publication. And I think I would like to encourage the researchers and the academics to get more involved in defining medical manpower supply in a more rigorous and scientific way.
I think the universities play a key role in moving forward the agenda of improving access, because universities are a place where lots of different types of people can get together, researchers, as Mark has mentioned, but also patient partners, clinicians, and really synthesize all the different perspectives that will improve the public policy. What we really need to do is get the ear of governments and make sure that we can translate our findings into actionable public policies.
The principles that we define can be applied to any area of the world if we have the basic data. And that is, I think, a tremendous impact.
There's always felt to have been a little bit of a crisis in family medicine, but it wasn't particularly apparent, I think, to as many people before. There were always grumblings about family physicians not being able to provide the care that patients needed, not being enough family physicians, being maldistributed. I think now we're at a tipping point where it has entered the public discourse in a way I've never seen before in my time practicing family medicine. I think there's a real opportunity now to bring people together and who will want to address this problem from academic settings, from government settings, from managerial settings, and from patient settings as well, to look at, can we understand the nature of this problem more effectively? Because if we can't understand it, we can't solve it. I think we're beginning to make some of those inroads now. The work is challenging. There will need to be resources contributed to understanding this problem in a more complex way than strictly counting the number of family physicians or looking at reports in the local papers of how many people that don't have a family physician. I think it's time to start engaging in some transformative analysis and some transformation of the healthcare system.
In getting this series up and going, we're delighted not only to have an inaugural seminar and others that will be part of the schedule in the coming months, but we would love to hear from other people who might be interested in contributing to the series, either by providing a seminar or perhaps contributing a paper based on their expertise and experience. So anybody with an interest is very welcome, and look forward to you contacting us.